Dear friends, it's a home stretch, which is this a little stretch between the sessions. I will moderate this session. I will not speak. We have experts on the subject. Those are our panelists. I'm just moderating, but Christian Querfeld from City of Hope, Sima Rozati from Johns Hopkins, and Francine Foss from Yale School of Medicine. Those are our disclosures. It's a CME activity, so you actually get a credit for listening to us. And the funding for this activity was provided by the educational grant from Helsinn Therapeutics. You will get one CME credit for the activity, and the goal is to, of course, learn to improve patients' care, and it's one AMA PRA Category 1 credit that you get. The learning objectives is to increase knowledge and confidence in interpreting mycosis fungoides, tumor microenvironment, and to recognize how it influences our therapeutic choices, to increase knowledge and confidence in evaluating cytotoxic and immunomodulatory mechanisms of skin-directed therapies, of systemic therapies, and to guide evidence-based durable management of CTCL. And so we will talk about CTCL as a disease of ecosystem, not just malignancy, but disease that exists in tumor microenvironment. And we will discuss how topical and systemic therapies modify that tumor microenvironment and provoke immune responses. I think we heard a lot about TME today, and one of the novel things and things that we are developing is role of fibroblasts and keratinocytes and other sessile skin cells that are there. They're not considered traditional immune cells, but they are quite immunogenic, and they play a big role in whatever is happening in the tumor microenvironment. And so this is something that we've learned today. And again, skin is immune ecosystem and sustained by multicellular immune network that drives cytokine polarization and chemokine trafficking that stabilize the malignant niche. And there is a two-way street. The cytokines that tumor produces, they are creating that kind of protective niche on one hand, and does not allow the immune system to actually interact with the malignancy effectively. And therapies reshape the ecosystem, not just killing tumor cells. And again, we've talked about TME quite a bit, but I really like that cartoon that demonstrates that tumor cells are actually secreting number of chemokines and cytokines, including CCL 17, 22, 2, and 5, and they reshape the Th2 responses. They bring in T regulatory cells and myeloid-derived suppressor cells and M2 macrophages, and the interferon promoting cytokine chemokines, rather CXCL9 and 10, they are not as effective as disease advances. And another important publication that relatively recent, less than 2 years ago, was about the role of B cells. And again, as disease progresses, now B cells becoming important players. And there are cases when patients are treated for other reasons with the B cell targeted therapies and disease gets better. So this is also something that we are learning quite efficiently. And so without much ado, I would like to start with Christian Querfeld, who will talk about architecture of CTCL tumor microenvironment, and we then will move to topicals and systemic agents and how they reshape tumor microenvironment.
Thank you for actually staying and listening to us. Promise this will be the last lecture on the microenvironment. In cutaneous T-cell lymphoma, we know a background of chronic inflammation and accumulation of cytogenetic abnormalities. And there are widespread immunologic abnormalities, such as a dysregulated, exhausted T-cell phenotype, which is a hallmark of CTCL. And therapeutic targeting of signaling interactions within this tumor microenvironment disrupts the supporting network for CTCL growth and progression. So these are early investigations that have been done before we even officially had a term of tumor microenvironment. And these were colleagues by Gary Wood, Martin Bermer, Rich Hoppe, who actually collaborated on several projects. And there were mainly histopathologic correlations, such as patients or biopsies who showed a higher Langerhans cell number, increased number of CD8 positive cells in tissue sections, and increased number of CD8 positive tumor infiltrating cells provides a better prognosis. Importantly, actually, there are data also out that shows a higher number of Tregs also pertains to a better prognosis. In contrast, there are data out who show worse prognosis, disease progression with dense infiltrates of tumor-associated macrophages, particularly CD163 positive, but also dense infiltrates of mast cells. So, however, now we see this microenvironment, and this is done by one of our fellows, who actually, we see how complex this is. We have the tumor cells, but the tumor cells can actually react with anything in the skin. So it can be the immune cells, it can be stromal cells, it can be keratinocytes, and even endothelial cells. They're all really critical, and whatever you focus on, it's a critical contribution to how our understanding how it functions. And when we look, in skin biopsies, this is just skin biopsies, and I see this when I'm on service and see biopsies that are done in our clinic. So patch plaque shows a very mild infiltrate, and it's mainly epidermotropic. However, they look really abnormal and hyperchromatic. In plaque, you have you have denser superficial infiltrate, a band-like infiltrate, but in tumors, you really, it's extending really into the deep dermis. And we have, and however, when you look, and actually this is then what we do in the lab, and we do multiplex imaging, and then you see actually the microenvironment becomes very interesting because you can assign those markers to specific immune cells, and then all of a sudden it becomes very colorful. In early stages, you have, again, a very mild infiltrate, and it's Th1 driven. You have Tbet as a transcription marker. So you have interferon gamma, interleukin 2, STAT4. In advanced stages, GATA3 is overly expressed. You have abnormal cytokine milieu, JAK-STAT pathway activation that also, particularly STAT5, leads to miR-155 upregulation, which is a classifier in MF versus dermatitis. So the PD-1, PD-ligand-1 expression then was initially, I think the Dutch group under Ryan Willemse identified. So in Sezary syndrome is really a marker that can differentiate erythrodermic from non-erythrodermic, and even from Sezary to mycosis fungoides. Other data shows this PD-ligand-1 is was more unclear where PD-ligand-1 in the skin is actually expressed, and it wasn't clear just by immunohistochemistry which cell type does express it. So we initially looked, and this was a very important paper where I worked at MSK under Jim Young's lab on cellular immunology, where we actually dissected the skin explants and took the migrated cells from skin explants, from epidermal, but also from dermal cells. And this is an example of the epidermal CD4 cells, which show elevation of PD-ligand 1, other checkpoints, but which was significant, LAG3 as well as ICOS and CTLA4. Interestingly, and I want to point out here, PD-ligand 1, which we could see in all stages, this was not significant to compared to healthy disease. So we did actually further multiplex imaging, and we could align really PD-ligand 1 with those macrophages, which is not easy when you actually just have a marker, single marker on a regular immunohistochemistry. Here we could align that PD-ligand 1 was mainly confined to the tumor-associated macrophages. There's good CD4-CD8 ratio. We all know this. This is an example from blood samples in Sezary patients. We all know this because the flow cytometry gives us a CD4-CD8 ratio, sometimes 100 to 1. We also know that in PD-1 is actually much higher in Sezary compared to healthy. And we also investigated these CD14 monocytes or M2-like monocytes or macrophages, which had a higher PD-ligand 1 expression compared to healthy. And definitely is more towards an M2 signature in Sezary compared to healthy. And we could actually plot this in a UMAP plot and define really an immune landscape, which is quite interesting. This is flow data, and showed that actually from those flow data you could see certain immune cells identified, and you can align PD-1 and PD-ligand 1 to where you can see actually the PD-1 is aligned to tumor. This is single cell analysis, and here you can align. You see that the gene for PD-1 is aligned really with the tumor cells, while mostly the PD-ligand 1 is assigned to or is co-expressed with dendritic cells and macrophages. So patients have an abnormal cytokine response. These were the highest we could identify in our samples, which is interleukin, immunosuppressive interleukin 6, interleukin 10. We had interferon gamma and TNF alpha, interestingly. We did also identified, and we looked into the two cell lines actually and conditioned in the culture medium of myelin and HAT78, which we analyzed. So they're all apparently expressed, also slightly different in both cell lines. So while higher TNF alpha is in myelin and interleukin 10 is much higher in HAT78, which may be relevant because HAT78 was isolated originally from a Sezary patient and myelin from a transformed patient. So we did actually use these two conditioned media to actually culture monocytes and actually get M2 macrophages or M2-like macrophages in the culture, which they showed actually high expression of CD163, which is one marker, and actually less expression, or actually to a classic M1 marker, which is CD8T. And here you can see they also express other CD206, which is definitely associated with PD-1, and also upregulated PD-1, and as well as PD-ligand 1, with upregulation of interleukin 10 in those macrophages, and downregulation of interleukin 1 beta, CXCL10 and CXCL11, which are usually the pro-inflammatory and more M1-driven cytokines. When we looked into roughly 48 samples, the NF-kappa, and this is just by RNA signaling pathway or hallmark analysis here, which shows NF-kappa B signaling as well as JAK-STAT signaling is upregulated compared to others, actually compared to healthy. We looked actually on multiplex, actually in imaging, we can see that phosphorylated STAT3 is really associated with tumor-associated macrophages that are positive also for PD-ligand 1 and CD163. Again, in those macrophages cultured in conditioned medium, they show upregulation of classically of STAT pathway, phospho-STAT3, STAT5, and STAT6, and downregulation of SOX proteins, particularly 2 and 6. The NF-kappa B pathway is also upregulated. Then it does correlate, the polarization does correlate with PD-ligand-1 expression. TNF-alpha is particularly the one who actually correlated highest and induced highest the PD-ligand-1. When we actually use the neutralizing antibody, and you show this on the right lower side, and the antibody actually could downregulate the PD-ligand-1 protein expression, while the other cytokines were not as effective, and expression still exists. So we know, and it was mentioned multiple times today, PD-1 expression is expressed, is a hallmark in Sezary syndrome, and particularly in untreated Sezary syndrome, which you can see the co-expression of PD-1 with CD3 positive T cells, which is much nicer than a regular immunohistochemistry with a brown or red color. We also know that TNF-alpha actually in the microenvironment, and cytokines are relevant for the microenvironment, promotes Tregs and immune checkpoint expression in those T cell subsets, which we did here, and you can see actually on the Tisney plots actually the upregulation actually on a TNF-alpha stimulation, which we could see that the upregulation of CD4 cells, Tregs, and slightly down regulation of CD8 cells. However, when you give neutralizing antibody, Tregs and CD4 cells were actually decreased, and upregulation of CD8 positive tumor infiltrating cells. Those aligned are also actually you can see here those cell subsets plotted actually, and with expression of cytokines following stimulation. So these are the tumor, the immune cell subsets on the left side. You can see between Sezary, tumor, plaque patch, and healthy. So we see really that in CTCL, you see upregulation of or highest expression of macrophage clusters, particularly actually the M2 clusters. And while this is very small in healthy skin, it does correlate with certain chemokine expression, which is particularly here on the person correlation coefficient. You can see CCL3 and CCL4, which are actually drives macrophage influx in lesions. It's much higher, as well as the upregulation in cultured macrophages of CCR1, CCR2, CCR5, which binds to those ligands. It does actually, interestingly, so we used anti-PD-ligand-1 and lenalidomide to see whether there are any functional changes in those tumor-associated macrophages when they're conditioned in CTCL cell line conditioned medium. And actually, when you add those drugs to it, you not only inhibit the phagocytic, you not only inhibit the migration, but it also increases the phagocytic capacity of those macrophages. They also downregulate PD-ligand-1 expression and downregulate actually CCR1, 2, and 5 expression. And these are my conclusions, actually, the future directions. The microenvironment, again, plays a really profound role in CTCL growth and progression. Upregulated immune checkpoint expression on T cells and various immune cells is a hallmark of CTCL. Identification of critical cytokines, signaling pathways involved in immune suppression, and tumor immunity is critical, because this plans out treatment as well strategies. The immune checkpoint inhibitors have shown promise in efficacy and impact on the CTCL environment. We still need to understand a lot of things. And not only immune checkpoints, various other treatment regimens can reshape the microenvironment. And so, that's it. Thank you very much.
Dr. Querfeld, you did amazing job. So we can move forward to the next speaker. We will move on to cytotoxic mechanism of skin-directed therapies, and Dr. Rozati will present next.
What a productive day, right? You guys are up? Very good. If not, my voice will wake you up. Great. So we're going to move on to talk a little bit of what topical treatments do, right? Why topical management matters? Because we know CTCL is not limited to the skin, right? It can involve the blood, the lymph nodes, and every other organ. But yet, skin is the primary tumor compartment, and it has a modifiable microenvironment through this ecosystem of immune cells, keratinocytes, fibroblasts, the microbiome, the barrier integrity. And we can access that through our topical therapy. And so today we will talk about a little bit about our most commonly used topical therapy and how they work and affect the TME. So first up is topical steroids. Everybody very familiar. We use it in all stages. Early stage is frontline, either as monotherapy or combination therapy. And early studies showed really good response. Like if it's limited disease, you can have great CR. If it's a little bit more, you have more patches and plaques, still you get a good partial response. And when they did biopsy the CRs, they actually did histologic remission, which can potentially mean durable response. And in advanced stages, we use it for residual disease, field treatment, and symptom control. What do we know about steroids in general and lymphoma? There's this idea that they work like two specific ways. One is they're directly cytotoxic to the malignant T cells by binding to the glucocorticoid receptor. And that GR-mediated repression of transcription factor-driven genes induces cell cycle arrest and suppresses mitotic activity and induces apoptosis of malignant T cells. But also they help reshape the anti-tumor microenvironment, especially in early stage disease. They are thought to reduce the number of antigen-presenting cells and sort of like disrupt the chronic stimulation of malignant T cells. They also downregulate adhesion molecules and basically change the immune cell trafficking and suppress Th2 cytokine production. But this is not the only topical we use. One of the major ones is microenvironment gel. And so, interestingly, microenvironment was first used as IV in 1947 for the treatment of a patient with MF. And after that, for decades, different formulation, different compounding was tried out to use it as a topical agent. And finally, a multi-center study led by Dr. Lesson and Dr. Young Kim for early stage MF compared the new gel formulation with a compounded ointment. And in their gel arm, where they had 90 patients, they saw over 60% response. Interesting, when you look at that Kaplan-Meier curve on your right, you can see that the time to 50% response was 6 months. Actually, a more recent study led by Dr. Ellen Kim showed similar response time. And so what does that mean? You have to be patient. Your patient has to be patient, right? And your residents and other providers need to be educated that they all need to be patient. And in this particular study, they saw 20% discontinuation of treatment due to skin irritation. I think in real life, we see it much more frequently. So microenvironment is a bifunctional alkylating agent. And so when it's applied on the cell surface, it goes through the epidermis, finds the malignant T cells, goes through into the nucleus. And what it does is that it causes double-stranded DNA breaks. which then impairs DNA repair and synthesis. And so that triggers increase in apoptosis caspase 3, and which puts these malignant T cells into apoptosis. And that apoptosis then releases cytotoxic inflammatory cytokines that then trigger activation of dendritic cells and influx of reactive T cells. And that also clinically then presents as contact dermatitis, which we're going to talk a little bit about. So for that reason, this study was done, which was a prospective randomized study called the microthermin-induced contact dermatitis avoidance study. They had 28 patients. Half of these targeted lesions were treated with microthermin gel alone, the other half with microthermin and triamcinolone. And what they saw is that the triamcinolone ointment increased tolerability of the microthermin gel, but did not change its efficacy. So if that is the case, then why do we say this cytotoxic profile inflammation is how microthermin works? I think there can be a lot of reasons. One of them may be because triamcinolone or topical steroids mitigate the inflammation, but it's not enough to suppress the immune stimulatory impact of the gel. Definitely we need more studies on that. And we had good discussions about it yesterday. Another treatment that is FDA approved is topical retinoid. So bexarotene gel is FDA approved based on a multi-center study that showed really modest response. It also has side effects, peeling, redness, pruritus, and it's very expensive, at least for my patients. Another one is tazarotene gel. It works a little bit different. That's a retinoid acid receptor. And so that one, there was a small study that showed really good partial response. That said, that study also used topical steroids for their patients. Has similar side effect profile. The way bexarotene works is that it modulates the RXR receptor, and it has direct anti-tumor effects, right? So it decreases survivin, which is an inhibitor of apoptosis, and so that results in growth arrest and apoptosis of malignant T cells. But also, it does exert immune modulatory effect because there's data shown that it decreases production of CCL2, which is a chemokine that is released by M2 tumor-associated macrophages. And this limits the recruitment of regulatory T cells, so that without relieving immunosuppression. Also, to a lesser extent, it does modulate the retinoic acid receptor and sort of has similar properties as other retinoids. Now, I think it's important to know the differences between these retinoids and how they function in CTCL, because then it helps us choose the right treatment for the right patient. And on the right is the bexarotene that this is the summary we just talked about, and on the left is tazarotene, which is a retinoic acid receptor modulator. And the way it works is actually indirectly modulating the MF niche. So it causes normalization of the epidermal differentiation, reduction of pro-inflammatory keratinocytes, and reshaping of the extracellular matrix. But also there's newer evidence that it does increase the number of CD8 T cells in the applied skin. So as you can see, there's some overlap between them. So the last stop, one of the other topicals that we use a lot is the TLR agonists, and toll-like receptors are of the part of the innate immune system, and their activation enhances immunity via several mechanisms and also anti-tumor immunity. And as part of the innate immune response, they recognize the danger signals, and then what they do is that results like triggers a cascade of adaptor molecules that then eventually induce induction of inflammatory cytokines, genes that regulate inflammatory cytokines, including type 1 interferons. So the T effectors are suppressed through different mechanisms and in the tumor microenvironment, as you can see on the right side, and activation of toll-like receptors either through microbiome products or through synthetic TLR agonists such as rozicimod, which is a TLR7, and imicamod, which is a TLR7, and rozicimod, which is a TLR7/8, they activate natural killer cells and cytotoxic T cells. And that increased lytic activity and induction on the malignant T cells then also releases cytokines that practice a strong Th1 immune response. So basically what it does, it shifts a cold immune microenvironment to a hot, hostile niche for CTCL. Rozicimod had a lot of promise. Unfortunately, is not available. Dr. Rook, in a small study, showed a great response, as you can see, before and after treated lesions, but also he observed regression of lesions that were not treated. And interestingly, when he did high-throughput sequencing of the TCR of the malignant T cells and the benign T cells, he saw after treatment that not only there was reduction of the clonal T cells, but also there was restoration of the immune repertoire. And unfortunately, currently is not available. So I reviewed these with you because what I really wanted to say was this slide, that topical therapies work on through multimodal mechanism. Almost all of them have a direct cytotoxic effect on the malignant T cells by disrupting DNA repair, by inducing cell cycle arrest, and putting the malignant T cells into apoptosis. But also, most of them directly modulate the local immune milieu by either modulating the number of antigen-presenting cells or enhancing cytotoxic reactive T cell activity. And finally, something that we are developing more and more data on is the modulation of other cells in the microenvironment, such as keratinocytes by causing normalization of the epidermal differentiation or restructuring of the extracellular matrix. And all of those are important when we choose topical treatments as monotherapy, as combination with other skin-directed therapy, but also an adjunct of systemic therapy, which for that we either are helping using topicals to modulate residual disease or improve symptoms. And with that, I want to move to our next presenter, Dr. Foss, and thank you for still listening.
We can move on to the last, but certainly not least, speaker, Dr. Francine Foss from Yale, who will talk about immune modulation of systemic therapies.
Thank you. So you've heard a lot today, and I know it's the end of the day, so I'll try to just kind of be brief, and I'll try to skip over things we already talked about. So, we're thinking about targeting drugs and, targeting drugs for CTCL, targeting not only the tumor cell, but also the microenvironment, and we've certainly heard a lot about microenvironment today. And fortunately, I think, compared to, say, 10 or 15 years ago, we actually have all these drugs now. We actually have checkpoint inhibitors, various monoclonal antibodies. We've done studies with the TLR antagonists. You heard about that. Histone deacetylase inhibitors, of course, and lenalidomide, and even some of these B-cell directed therapies that we heard about. So I just want to briefly touch on like how some of the things that we use every day in the clinic really impact microenvironment and how we should be thinking about that. So we all know a lot about brentuximab, and we know that it's targets CD30. I don't have to go over this. We know that CD30 is expressed to some degree in the microenvironment, and also that there can be unconjugation of the toxic moiety, which by itself could be liberated and could induce cytotoxicity. This is the Kansas study. I don't need to review it. You all are aware of the data. What was interesting, though, is when we start drilling down on the level of expression of CD30, and I think Ali covered this morning, first thing, is that the evidence from this trial, if you look at low level of expression versus higher level of expression, it didn't really seem to make any difference. And you can see the distribution of different levels of expression across the patients in this trial. Other studies have also echoed those same results. The two IIT studies that were conducted, one of which didn't even require the expression of CD30. The other required any percentage of CD30 positivity. And likewise, if you look at the bar graph below and you look at CD30 levels being high, low, or undetectable, you can again see, well, there's a slight advantage to having a slightly higher CD30 expression. Certainly, those patients who had low or even absent could respond. And just to give an example of how that actually plays out in the clinic, one of my patients, a 46-year-old gentleman with tumor stage MF, who actually had an evolution toward focal large cell transformation and then large cell transformation over time. He initially had very weak CD30 staining when we first saw signs of early large cell transformation. However, we gave him brentuximab anyway, and after 3 cycles, he actually had a complete response. We stopped it for neuropathic pain. And you can see the different biopsies, and this mimics the fact that you can see different levels of CD30 expression in different lesions at the same time. The lesion that you're looking at doesn't appear to have much expression. It's like less than 1%. And then if we looked at another lesion in that same patient, we did see weak CD30 staining in some of the larger cells. So again, an example of how we really need to look beyond just CD30 expression. So CD30 staining in normal tissues, what about that? Is there a microenvironment effect here? Are we targeting anything other than tumor cells? It was actually really hard to actually get this data because you'd be surprised that there's very little data out there where people have looked in the microenvironment in these patients. What I was able to piece together was that it's been reported that there's transient expression in activated B, T, and NK cells, which is less than 1% of circulating cells. And the range can be from low to strong. B-cell immunoblasts at the edge of the germinal center can be positive, and subpopulations of CD4 positive, CD5 Rho positive, and CD8 positive cells in the lymph node can also sometimes be positive. So how this plays into our patients and what's happening in the microenvironment, I think still remains to be seen. We talked a lot about MOGA. Again, I won't reiterate any of the clinical data. You're all familiar with the very nice data and the waterfall plot showing that many patients had a response in different compartments. And again, that the response was slightly higher in blood and slightly higher in Sezary. We wanted to drill down again and try to ask a question about what else might be happening. I'll talk about skin rash in a minute, but I also want to talk about the degree of lymphopenia that we've all observed with MOGA. So as we conducted this study, I think many of us saw that our patients were becoming lymphopenic, some but not all. And so the question we had is whether or not lymphopenia as a secondary effect of this drug had anything to do with clinical response. So we graded the degree of lymphopenia based on the shift from baseline. So from grade 0 to 1, 0 to 2, 0 to 3, 0 to 2 or 3, or 0 to 4. And we looked at the MOGA patients and, of course, the vorinostat patients as a control. And you can see that there was varying degrees of lymphopenia that were observed. Only 6% of patients had up to grade 4. Many of them were grade 2 to 3. And then if you look at the outlined red box below, this is the overall response rate in lymphopenia, looking at the correlation between those two. Those patients that achieved an overall response had a higher chance of having lymphopenia than those that didn't. So any patient who had a shift from grade 0, there were 43 patients there, who achieved a response, whereas the patients who didn't have that shift, there were 4 and only 11% responded. Now, the p-value was significant for this, and you can see the graphic outlined in yellow just shows you, again, a graphical representation of that. And so what we found, and we did publish this paper recently, is that of the 104 patients with any degree of shift from 0 to any grade of lymphopenia, 43 achieved an overall response, 41%, versus 4 of 36 or 11% who didn't develop the lymphopenia. There was no association between B class and overall response when we looked at that. And that suggested that the lymphopenia was not limited to just getting rid of Sezary cells, that it was also normal populations of cells that were being depleted as well. So I think this is an important and interesting finding as we see how our patients are doing clinically. And again, we talked a lot about skin rash, so I won't belabor skin rash. You heard about the median onset of skin rash, the fact that it occurs frequently in patients and that it is correlated with clinical response. So if you look at, again, looking at the non-responder and responder here, for both MF and Sezary syndrome, you can see the correlation in that those patients that had a skin rash tended to do better. And again, just another example, you saw this again earlier today. One of the patients who developed a skin rash, biopsy of which showed no evidence of the cutaneous T-cell lymphoma. Managing the skin rash, again, we talked about prednisone, holding therapy, but the other thing that we've been doing, and I think other centers are doing this as well, is we added photopheresis early on for these patients, and we used that partially to try to taper back the steroids, and that proved to be actually effective for a number of our patients. And we also heard a little bit more about the different types of MAR, and I won't go through this in detail, but just to show you a very nice graphical representation of the 6 different types that were identified. When we start thinking about microenvironment effects, it's not hard to imagine that there might be some differences in each one of these different types in terms of which populations might be modulated and what the cytokine and chemokine profiles are in these different types of MAR. And then again, I won't belabor this either because I think we talked a little bit about what actually is happening in these patients and what the different immune responses are. And this is one paper looking at single-cell RNA sequencing showing CCR4 expression primarily on the malignant clones and regulatory T cells, which were both reduced in MOGA-associated drug rash. And also shows the CD8 infiltrate with a less exhausted phenotype and more cytotoxic phenotype. Again, these are things that we've talked about today, and showing the importance of focusing on microenvironment in that situation. And then the other drug I want to talk about is E7777. This is the old ONTAC, the new Lymphir. Basically, it's a fusion protein with interleukin-2 hooked up to diphtheria toxin. We know that it kills cells expressing IL-2 receptor, but we also know that it's capable of modulating and eliminating immunoregulatory T cells as well. The clinical trial, again, I won't go through this in detail. Many of you are familiar with this. Basically, this trial reiterated what we saw previously with ONTAC, looking at a similar population of patients, many of whom had MF, with a few Sezary patients included here as well. And showing you the waterfall plot and the swimmer's plot here for the overall response rate of 37%, the median duration of 6.4 months. However, there were patients who had responses greater than 1 year, and that was really encouraging here. So what about the level of IL-2 receptor expression, and does that predict response to ONTAC? So I think earlier today we saw some data that I think was generated by Madeline Duvik from the earlier study with ONTAC, showing that patients who had a higher level expression had a higher chance of responding. But this is a study that was done by a Japanese group where they did both PTCL and CTCL patients. They treated them with the conventional doses of denileukin diftitox, got a very similar response rate for CTCL at 31%. However, CD25 expression was not required for entry onto this study. And when they then started to look at response based on the level of CD25 expression, those patients with less than 20% had a 16% response, greater than 20% was 38%. And so you can see some of the raw data here. And so again, that suggested certainly that maybe it was better for the higher level of expression, but that those patients with lower levels could also respond. And interestingly, while the FDA did look at CD30 expression as part of the label indication for brentuximab, they actually did not require it for denileukin diftitox for this newer version. And then other work that's been done recently looking at this whole Treg question has been done in various solid tumor settings. And this is just one study where they combined pembrolizumab with Lymphir, and they showed clinical benefit in this GYN oncology group of patients. So they showed a 27% overall response rate with 4 PRs and a clinical benefit of 33%. But more impressive, I think, was the progression-free survival of 57 weeks in these heavily pretreated patients. So again, I think this is interesting data, and there are other studies underway looking at in other solid tumor settings. So I think clearly we want to go back now and start studying our patients with CTCL and looking at some of these microenvironment effects that we've heard about today, and see whether or not we can look at whether a certain microenvironment is predictive of response and to what degree we really modulate Tregs in the microenvironment with this molecule. And then lastly, again, we've heard a little bit about CD47 today and on macrophage, eat me, don't eat me signaling pathway, and how inhibition of that pathway can activate the macrophages. And this, again, is work that Christiana did looking at intralesional injection of an anti-CD47 antibody. And you can see very nice clinical response here, but also more importantly, when she looked at the actual effects in the microenvironment, you could see the patients who responded had increase in macrophage signature. There was increase in neutrophil signature, as well as other cytokines that were modulated, all pointing to the fact that you were improving the activation of the macrophages in this setting. Unfortunately, that molecule hasn't really gone forward, as we all know, but there is a newer one available right now in clinical trials. I don't know if many of you are involved in this trial, but this is ELA-026, which is a humanized IgG1 monoclonal antibody directed against SIRP alpha beta 1 and SIRP gamma as well. So SIRP gamma is expressed on T cells. And again, this works by ADCC. And if you just kind of look at, in this particular patient, you can see at baseline, you can see the higher level of expression of the malignant T cells, and then you can see after 4 weeks, you can see that the malignant T cells are significantly depleted. And so this shows very strong clinical activity. Clinical trial is very early on now, so hopefully we'll see some good results from that. And then very last thing I want to talk about, we didn't talk much about this today, but there is actually a CD3 PD-1 bispecific antibody that's in a multi-center clinical trial for patients with T-cell lymphomas. With CTCL, we've heard a lot about the expression of PD-1, particularly on Sezary cells, and that led to those patients being included in this trial. So we're still very early on, but I've treated a number of these patients with CTCL and Sezary. I'm definitely seeing a lot of disease stabilization and definitely seeing some patients with response. I don't know if anyone else wants to comment on that who's involved in the trial. So just in summary, we just touched on a couple of things. We touched on again, what's happening with mogamulizumab, and I think we have somewhat of an understanding of the microenvironment effects of MOGA. Likewise, with brentuximab, we have less, but we know that certainly there are normal populations that could be targeted in the microenvironment. And then with denalucan diftitox, again, another Treg depleter, I think we're still very early on in terms of understanding really the microenvironment effects of this, but hopefully that will be coming in the future. Thank you.
Thank you so much, Francine. There are a couple of questions from the audience about optimization of mogamulizumab for maximal benefit. And, when you manage MAR, how do you actually treat with MOGA? And, when it's difficult to distinguish MAR from CTCL, how do you optimizing MOGA therapy? And
Oh my goodness, that's a lot. Okay, where do we start? Where do we start? So, okay, just briefly, how long do you treat somebody with MOGA is a very good question. So we all have people that are responding. They may not be a complete response, but they're definitely improving. So what we're doing is spacing treatment out, to monthly. And then it really just depends on the patient, and I think we really don't know the answer to that. So I have this discussion with patients. I don't know how long to treat you. And I think it really just depends on a negotiation and whether or not there are any toxicities. With respect to MAR, it occurs in a lot of patients. Management, again, I think is somewhat patient-specific. Stopping the drug briefly, using topical steroids, and then maybe systemic steroids to see whether or not you could ameliorate the reaction. And if patients don't respond right away, as I said, we add photopheresis. There are some patients that have MAR that's very stubborn. It goes on for, even despite all of these interventions. So we've also used methotrexate in those patients successfully. As far as reintroducing, I'd be interested in hearing what other people in the audience have to say about that, but we have been able to successfully reintroduce it in some patients. And again, I think it really just depends on the severity of the reaction. Other parts of that? You need to answer.
There are very loaded questions, and I don't know if we can really address them like in such a quick way in terms of what clinical factors guide your selection of systemic agents and sequencing of targeted agents in patients with CD30 positive disease.
Okay.
I know.
Well, CD30 positive disease, I think we obviously think about brentuximab. If it's a suitable treatment for that patient. We have clinical trials, and I'm sure others do as well. We have a trial combining brentuximab with pembrolizumab. So I think there's no reason why you can't give single-agent brentuximab, but data that's emerging now about the microenvironment and the suppressive effects in the microenvironment make me think that combination studies are probably better, particularly for those people with more aggressive and transformed disease. But I think it really depends on patient factors. Now that we're going to have Lymphir, denalucan diftitox, one of the issues for that had been previously, looking at CD25 expression. But since we now don't really need CD25 expression as per like the insurance companies approving it, I think it's going to be difficult for us to kind of figure out how that fits in. I mean, certainly we see a lot of patients with tumor stage MF that do not have CD30 positivity. So I think that's really one place where I would start with that.
Thank you so much. It was amazing presentation. We rarely look at these systemic agents in a way that would go beyond just malignant cell killing. So I think it was quite informative. We have a couple of questions, actually. And one of the questions is, how soon could biomarkers be integrated into clinical workflows? Well, I think we are integrating them now, and there are many therapies that are used now that are based on biomarkers, like CD30, for example. We use CD25 for some other things. So I think they are not as sophisticated as they will be, hopefully, in the near future. But biomarkers are something that is part of our everyday life. Any thoughts about differences in TME in FMF specifically. So Christian, if you want to comment on follicular tropic mycosis fungoides and TME versus regular garden variety MF.
It's a good question. I haven't formally analyzed that. I believe, can everyone hear me? So there is, however,
Is the mic on?
Oh, sorry. Can everyone hear? So I haven't formally analyzed them. I do know that there are different T-cell receptor sequences in the environment. There are also different cytokines, such as particularly interleukin-13. And there also appears that the number of tumor-associated macrophages, M2 macrophages, plus myelosuppressor cells are much higher.
There are a couple of questions from the audience. Maybe, Sima, you can respond to that in terms of where does microenvironment fits into kind of current armamentarium of different treatments. How would you select when to treat, when not to treat? How does it work with phototherapy?
So that's a great question, and just due to time, I took all those slides out. So I think microtherapy can be used for early stage disease, right? Especially easy to use when patients have limited stage, limited patches and plaques that are not intragenous areas and not on their face. Not that they cannot use it, but you just have to be more careful and walk them through it. We also can use it for advanced stages. You know, again, like when there's few plaques that are not responding to an otherwise effective therapy, we absolutely can use microtherapy. And with phototherapy, I think caution was advised, especially with fair skin patients, right, because of possibility of increasing risk for skin cancers. But we had the discussion yesterday that might be very effective for our darker skin patients. That said, you know, all of these, you have to gauge what the patient is willing to do, right? Like doing 3 times a week phototherapy, and then when am I going to put this microtherapy on, and what is the timeline? And so I think all of those we have to take effect, and also the irritation that is caused by microtherapy, and educating our patients like how to deal with that, and holding their hand to really walk through that part, I think is important as well.
We have one more question for Dr. Rozati about other topical agents, about use of tacrolimus, 5-FU, crisaborole, and ruxolitinib.
So great question, and if I had an hour, I would talk about all of them. I think ruxolitinib, we talked about it a lot today, as topical treatment. I think there's definitely a role to use it as a topical treatment. Although we don't have any, like good solid published data, but it seems like it does not have all the cautionary tales of the oral. I do use tacrolimus a lot, especially for around the eye, genitals. I use it in combination with topical steroids. And also, there was a small study with pipecrolimus, whatever. Yes, thank you. And from Italy, that they showed there was no side effects, was well tolerated, and so I believe we also put tacrolimus in the topical in the NCCN guidelines. So I think definitely has a role. I personally don't use FUDEX that often. I think if I wanted to, like as a topical, I would rather use imicamod in combination. And I think that was pretty much it.
There is a question for Dr. Rozati about how to dose imiquimod.
Great question. I think for me, I use imicamod the same way I would use it for superficial basal cell carcinomas, which is I start slowly and then up the frequency. So I start them usually like 3 times a week, and then I tell them if they don't have a reaction, they can go to 4 times a week and then do it Monday through Friday. I do have some patients that are on it every day, and they have a little bit of inflammation. I think a lot of times, though, before they come back, like we get into a habit that they stop the imiquimod before they come back because, you know, their lesions actually get juicy. And so it's hard for me to say if they have, like, how much residual diseases and how much response. But when they give it a break and they come back, we see good response and we keep continuing. Occasionally, I have to use topical steroids to calm down the inflammation.